This is the hip hop case. Let's talk about the pooling matters lens. So I'm back in the base case. We've got two ORs in each track, a dedicated anesthesiologist and a dedicated surgeon in each track. Nobody in the pools here. The question is, is it better to have dedicated ORs or maybe to pool them all? So I'm going to run one scenario for you here with pooling the ORs. So instead of having two in each track, say put 0 here and 0 here. I'm in the simulation main tab again, and I'm going to put all those ORs into a central pool. So the surgeries could happen in any of the 4 ORs. It's just a little bit of an administrative move here. And maybe the surgeons won't like it because they don't have dedicated ORs, but we're going to see if this makes a difference relative to the base case. Also want to put the anesthesiologists into a pool. Now, I know it says CRNA pool, but I'm going to just take the actual anesthesiologists out of here. It's not important to have a dedicated anesthesiologist. There's no patient relationship there, so we can do this. And I'm going to put those 2 anesthesiologists into the pool. That shouldn't really be called CRNA pool. They're really anesthesiology pros. Okay. And let's run this. So moving from dedicated ORs and dedicated anesthesiologists to pooling both of those 2 kinds of resources. Just see how this goes. And again, you need to replicate it multiple times here to get a sense as to whether this is a meaningful innovation. This particular one, I mean, there may be a little bit of overhead, a little bit of administrative maneuvering to get the pooling of the ORs to go, but this is relatively low cost, right? The anesthesiologist, they're just the same 2 folks, but now pooled. So that's not an expense item. So pooling often comes at relatively low cost. Let's run this to completion. Just going to show the timer here. We're 19 minutes into the day. Let's speed through this. And so we got a 4 and 4. So no big changes here. Here are your flow times. Let's try it again. 4 and 4. So what's happening is you can see that I've got no ORs here or here. And there's 4 here, and it's 89% utilized. The CRNA pool, the anesthesiology pros are the big limitation here. And the surgeons are anywhere between 70 and 80% utilized roughly. Okay, one more time. Again, we got 4 and 4. Now, these changes that we're considering, these marginal changes, in other words, one at a time, changing the pooling on the ORs or changing the number of CRNA, the size of the number of CRNAs hired, which we're considering them in isolation. It's totally conceivable that, in unison, in conjunction, in combination, that there could be a pop. And that's something that you could potentially explore. So let's just look one more time. And you can see flow times at around 200 minutes, which considerably beyond the 90-minute inter-arrival time. So again, the folks end of the day are experiencing unfairness, longer wait times. Here you got 4 and 4 again. Okay, so that's the pooling matters. Just another lens, and the lens basically surfaces ideas for pooling. Just want to note that we cannot pull the dedicated surgeons out here because we have to preserve that patient relationship. So the patient's going to come down this pike, and that surgeon that has done the consult needs to be present there. You can't put the surgeons in the pool.